Good morning. We are going to start now a very stage for value-based payments. He has a lot of material to cover, but he had a previous commitment. So we know that parking was a challenge this morning. We thank all of you that were able to find parking spots. And so we are going to dispense with introductions. We would just ask for people on the phone to make sure that you sign in the comment box so that we can capture those of you that are here as a requirement of attending for learning collaborative purposes. My name is Carol Moser. I'm the Executive Director, and thank you again for joining us this morning. I think we're going to have a fabulous discussion about value-based payment. We have a great group of panelists that will be with us, the managed care organizations that you'll be able to fire questions at. And by the way, if you see a group of us leaving at 11:15, we are not trying to be rude, but we have our interview and our midpoint assessment today with Myers and Stauffer. So it's a very packed agenda that we have this morning. I will go ahead and introduce JD so that he can start off with his presentation, and you have his bio in your packet. So JD Fisher has a Master's of Public Health, Health Systems and Policy with significant training in public health policy research and analysis. JD is currently employed at the Washington State Healthcare Authority as a Senior Health Policy Analyst within Healthier Washington. So if you would all help me welcome JD Fisher, I would appreciate it. Thank you.
Well, thank you very much. Can you all hear me okay?
I think we can now.
And can you see my screen?
Yes.
All right, 2 for 2. Well, thank you very much for the opportunity. I appreciate it. I am a bit under the weather today, so I apologize if there's some coughing in the background, but I will do my best to get through this. And there is a lot of material. One thing I want to note is that this is pretty preliminary data that I'll be sharing from this year's survey. It's pretty raw as far as the graphics go, so hopefully later this fall I'll have some a more refined presentation, and we'll actually be able to do some more regional focus, and so would be happy to come back at a later date to give some more specifics to the Greater Columbia experience. But for now, a lot of this is going to be fairly general from early takeaways. But I'll just jump right in. Just want to provide some background, which I'm sure most of you have seen, but give you just a quick shot of where the healthcare authority is coming from. We are the state's largest healthcare purchaser, purchasing benefits and healthcare for over 2 million Washington residents. That spans Apple Health, public and school employee benefits. And across those 3 books of business, we are doing our best to leverage our purchasing power to reward patient-centered high-quality care, drive standardization where it makes sense, and reward our partners for quality and value. Our approach to purchasing is really threefold: transforming care that happens on the ground in the clinic, making sure that individuals' whole person needs are met, their physical and behavioral health services are met, that there's a no wrong door approach to care, and trying to find ways to better use data to inform purchasing decisions and care practice transformation. We do have some robust purchasing goals, and by 2021, by the end of 2021, we aim to have 90% of state-financed healthcare in value-based payment arrangements, along with 50% of the commercial market. This is where we believe that our role as a purchaser can have a broader influence across the state in markets beyond Medicaid and the commercial care that we purchase for. We're closely tracking with what's happening on the federal level and doing our best to align with CMS reforms like MACRA and the Quality Payment Program. And our goal is really to achieve our vision of a healthier Washington, that by containing cost growth and improving outcomes for both consumers and providers, that this state will be healthier, that care will be delivered in a new way, in a way that better serves our population. We're doing this through an aligned purchasing philosophy, whereas historically Medicaid and public employee benefits have operated in fairly siloed environments. We are strongly and aggressively trying to align our strategic changes across those programs to achieve the greatest common transformation across both. We have a value-based purchasing roadmap that we update annually that signals our progress towards these goals and highlights specific initiatives. You can see on those green bubbles on the right, lower right-hand side, just our annual targets. Our goal for 2018 was to be at 50% across Medicaid and public employee benefits. We're pretty confident that we'll have met that goal. We are still waiting for some financial data to come in to calculate that, but we were at 43% in 2017, which was well ahead of our goal for that year. So, so far so good, but as you can see, the numbers get more aggressive as we get closer to 2021, and so I'm sure you're all aware in your own work that the further you get down this road, the more challenging it becomes to make incremental progress. But we're confident that we'll get there. We have aligned our language and definitions for value-based purchasing around a federal framework for payment categorization. This is the CMS APM framework, the Alternative Payment Model Framework put out by the Healthcare Payment and Learning Action Network. This framework just helps us when we communicate about purchasing models and when we put things in contracts that we can have a clear definition that is somewhat standardized at a national level. And our standard for VBP rests in categories 2C through 4B on this framework. And for those of you who have paid closer attention to this, this is actually the original framework. This group updated this framework about 2 years ago. What they really just removed 2D and added another category in category 4. But since we already had this in contracts and was already driving a lot of our work, we made the decision to stick with the original framework, at least until the end of the Medicaid transformation, just for consistency. When we talk about value-based purchasing, this is really a system-wide approach and requires buy-in and participation from a variety of stakeholders, which ultimately invariably leads to needing specific role clarity. We identified 4 domains where roles are important to be defined: defining, delivering, measuring, and reinforcing VBP. When we talk about defining VBP, this is how we're articulating our goals and which programs will align with those goals. In terms of delivering VBP, we're talking about actions that will be taken to achieve those goals, directly or through some type of indirect influence. Measuring VBP is how we identify which measures we'll use to assess progress and how we'll support the measurement process. And then reinforcing VBP is using levers unique to each stakeholder to assure that progress is being made towards those goals. We did some work with Manat over the past year to tease out these roles and expectations for a number of stakeholders. This list isn't exhaustive, both the colored boxes and also the stakeholders. We realize there are important stakeholders and partners that are left off of this, stakeholders like patients and consumer advocacy groups, community-based organizations, partners like tribal governments and tribal clinics specifically. So having them not in this table isn't a matter of us not recognizing them as playing key roles. It's just there's only so much room on a slide. And being that this is really just a conversation starter. But to highlight a few things, this is color-coded, so the bluish boxes are what we've identified as that could be considered primary roles for these stakeholders and partners, and the more pinkish boxes are those roles that could be considered secondary. So when it comes to the ACH and defining VBP, it's critical that the ACH participate in articulating the business case for using DSRIP projects to align with VBP and support VBP. Another secondary role is measuring VBP, and this is where ACHs have done a phenomenal job encouraging and incentivizing provider participation in our annual surveys. And then there are two primary roles that we've identified for the ACH, both in delivering and reinforcing VBP. This largely delivering through supporting clinical practice transformation and supporting health partnerships and investing in areas that support VBP. To reinforce VBP through the allocation of DSRIP funds towards projects that support or reward VBP adoption, and focus on DSRIP projects that are consistent with aspects that providers need to become ready to engage in VBP. So we could probably spend a whole hour talking about this table, and that would be a wonderful conversation. But for time, I'm going to move ahead, and this is maybe something we could come back to in the discussion portion. So when we talk about Apple Health specifically, we have done a number of things to drive value-based purchasing through our contracts and through Apple Health. Starting with the MCO contracts, we implemented a withhold that was effective for the first time in 2017. MCOs are able to earn back this withhold in 3 different areas. One is through general VBP adoption, just contracting with providers in value-based arrangements. The second is that within those arrangements, they are to hold providers accountable through incentives. So we set targets for the number of dollars that must be paid to providers in the form of incentives every year. And then the third bucket is through quality improvement. Now you'll see that in those, the middle and the right-hand buckets, the provider incentives and the QIS share, the quality share, it's TBD for 2020 and 2021. That's due to the budget proviso that came through the legislature this year that required a change in the quality portion of the contract, and we're also doing work to identify a new target for the provider incentives portion. The major change to the QIS is that we're no longer excuse me, no longer using our homegrown quality improvement model to assess performance. We are instead using a bucketed approach where MCOs must perform on each quality measure by either achieving the top national Medicaid quartile for that measure or demonstrating statistically significant improvement on that measure from the previous year. So we're still working on the language that will dictate that and lay it out, and we've informed the MCOs what those quality measures will be, because in that proviso language it changed how we select and put quality measures into the contracts. And actually that's a segue into the next slide. These are the new measures for the managed care organizations effective January 1st, 2020. You'll see that there's a top section that is measures that are common across all 5 MCOs, and then that bottom section are measures that are specific to each MCO. And this was part of the budget proviso language that required the healthcare authority to select measures from each MCO where there was demonstrated need for improvement, but also had a clinically significant impact. So there's a lot of consistency in this measure set with previous year measures, so not deviating too much, but you'll see there at the MCO specific measures there is some differences. For instance, coordinated care and CHPW will have the follow-up for ADHD medication, and Molina and United will have comprehensive diabetes care for HbA1c control, and Amerigroup will be measured for diabetes medical attention for nephropathy, however you say that word. I'm not a doctor. But So we can talk a little bit more about this, although I may not have the expertise to answer your questions. We have a team, our clinical quality and care transformation division here at the healthcare authority. Sorry, I'm getting some feedback over the line. There we go.
There you go.
So anyways, might be best for me to take questions back to that group, but this is what I can share at the moment. So when it comes to Medicaid transformation, we've tried to align the work we're doing through the 1115 waiver with what we've done through the MCO contracts, following the same targets for adoption and using the same land framework. One thing we have done is added a sub-target for MCO district incentive earn back to ensure that they are moving towards total cost of care arrangements that begin with category 3A. So that's the reason for that second column on that right-hand table. So now to the survey, some preliminary results from our survey just conducted this past summer that was covering calendar year 2018. Just an overview, we issue 3 surveys, one to the managed care organizations that occurs through the VBP validation process for their contracts, one that reaches commercial and Medicare health plans, and then one that goes out to providers. The purpose is to track progress towards our value-based purchasing goals and to assess experience from our partners and stakeholders. We issue to all Washington state health plans, including the 5 MCOs, and to provider organizations. One thing I want to note is that we've started putting as a requirement in our contracts with health plans that they respond to this survey every year. So we think that will drive better response rates over time. The MCO and provider surveys add a bit of regional context and information. And we designed these surveys to ideally be completed by administrators, both to try to avoid provider clinician burnout, but also to make it a little more user-friendly and something that can be completed in a fairly short amount of time. When we talk about the health plan survey, these are the respondents from this year's survey. All 5 MCOs completed their Medicaid-specific survey, and all 5 also completed the Medicare and commercial survey. In addition to those MCOs, Aetna, Humana, Kaiser, Premera, and Regents all responded to the survey. And you know, with an asterisk, there's only 2 of those health plans that we do not have a contractual relationship with at the moment. So another example of just the breadth of our purchasing influence in the state. Some quantitative results from the health plan survey, and due to we're still waiting on final revisions and the write-back process for the MCO survey results. So our independent assessor is still working with each MCO to come up with the final numbers. And I haven't had a chance to analyze the health plan survey yet at this level. So this is all data from last year's survey. So it's 2018 survey data that covers calendar year 2017. In Medicaid, we were hovering right around 50% VBP, which lagged behind both Medicare and commercial, but was still well ahead of the target for that year. So I'd say across the board, we're encouraged by the progress here. Medicare seems to be leading the way, which maybe isn't too surprising given the work that CMS has been doing in this area. And you can see there at the bottom that we have made significant and steady progress from a statewide perspective. 2016 was the first survey of this nature, and we were right around 30%, and 2 years later, we were above 50% across the board. And again, by ACH, and this was Medicaid data specifically from the managed care organizations. And again, this is 2018 survey data. Each ACH was also right around 50%, with a few being fairly well over. Greater Columbia was at 47%. So when it comes to considering where we think you'll be this year around and covering calendar year 2018, I'd be pretty confident that you'll be achieving the interim targets and on your way to continued progress. Now, so now we get to the provider survey, and since we did it in SurveyMonkey, there's some kind of automatic data analysis that tool allows. So some of these tables are already populated, and these aren't as attractive or aesthetically pleasing as I would like, but they'll serve purposes for this kind of early review. So we had over 170 providers access the survey and at least begin filling it out. As we go down, you'll see that fewer providers completed questions further down the survey as it goes. But a really good, at least, access rate. And something that we can consider for future years is how to either rearrange the survey or better incentivize participation to ensure that there is a greater degree of completeness. But some numbers I want to highlight there. 77 behavioral health providers responded, and this isn't exclusive, so they could be other provider types and just provide behavioral health services. So it's not exclusive to those organizations that are solely behavioral health providers, but still an important number. There were over 20 organizations that responded as rural health clinics, federally qualified health centers, or critical access hospitals, and 22 hospitals. So some good representation from rural partners and behavioral health partners. We asked for the number of employed clinicians at the full-time equivalent. A pretty good spread. This year we had more providers respond in that 500 and above level than before, so that's good, but still really solid representation from small and medium-sized providers. Some more qualitative information, and this was really, the provider survey is really mostly focused on this qualitative experience type questions. In our experience, providers are less likely to provide robust quantitative information in terms of revenue by APM category. So we've tried to emphasize this qualitative side to get the best information we can. So we asked a question about PCMH certification and PCMH culture this year. Only 36 respondents said that they have achieved certification, but 96 said that they do follow a PCMH culture. So knowing that there is an administrative burden to achieving certification, there is something to be taken away that a lot of providers are looking to follow the PCMH culture. We asked about which ACHs are these respondents directly working with. And that we tried to make that fairly broad, you know, whether it's involved in project plans, actual governance structure, or attending regular meetings. Greater Columbia had 13 providers respond in the affirmative to this. That doesn't mean that there are only 13 providers from your region that responded. Maybe some are just more passively participating or declined to select Greater Columbia here. But this is another thing that I'll be able to dig into with greater detail once I get a chance to do some more in-depth analysis. In terms of which providers received revenue in various markets through VBP, 36 are participating in Medicaid VBP, and that number gets smaller as you go to Medicare and commercial. But you'll note that only 44 respondents answered this question. So it's not 36 out of 170, it's 36 out of 44. In terms of VBP readiness, 89 providers responded to this question, and most are in the somewhat to mostly ready area, whereas there's still a significant number that are not very ready or not ready with limited or inadequate capacity. So definitely a lot of work left to be done in the readiness realm. In terms of experience with VBP, we asked both about the provider organization and individual clinician experience. And the numbers are pretty consistent, both a fairly even spread from neutral to positive. Clinicians' experience is mostly around the neutral, with a lot of respondents selecting the other category, and they were able to input text and tell us a little bit more. So I haven't had a chance to pull out any themes from that yet. When it comes to barriers and enablers towards adopting VBP, only 51 providers responded to the enablers portion. Of those 53, 21 selected aligned quality measures and definitions, trusted partnerships and collaboration with payers, and a medical home culture with engaged providers as the top 3 enablers. So when we think about what to do with this, these are areas we can focus resources and communications to try to bolster, as these are things identified as helping folks participate. In terms of barriers, lack of interoperable data systems remains one of the top barriers. This is consistent with previous years. Misaligned incentives and contract requirements, and lack of access to comprehensive data on patient populations. Similarly, these are areas we can collectively work together to try to align resources to address these barriers. When we asked how their experience with last year's top barriers has been, and the top 3 from last year were interoperable data systems or lack thereof, lack of cost data, and lack of comprehensive data on patient populations. Most are just about the same. So not seeing a lot of progress towards addressing those barriers from previous years. We asked a number of questions about health equity and what providers are doing around race, ethnicity, and language data. Most providers are collecting data on these 3 categories, whereas only a small number are assessing performance by these categories. But then a larger number are implementing programs to address disparities. So it's encouraging that while they may not be measuring their providers' performance, they are doing they are conducting activities to address disparities by race, ethnicity, and language. Asked about clinical integration using SAMHSA's 6 levels of collaboration and integration. Pretty even spread, but a large concentration there at the first 3 levels, but still quite a few in levels 4, 5, and 6. 55 respondents say they intend to move to a higher level next year, and 47 respondents are striving to align with the Dr. Robert Bree collaborative recommendations for behavioral health integration. So I'd say those are all encouraging signs. We asked about what types of technical support providers have received. Practice transformation was the #1 category, but then when we asked what would be most helpful, VBP and HIT technical support rose to the top as what would be most helpful moving forward. And I think sometimes there's a little blurred line between some of these, because you could easily connect the dots between a lot of practice transformation and VBP readiness. I think there's a lot of things that happen at the clinical level that really set up providers to participate in VBP through some of that practice transformation. So I wouldn't say this is too surprising, but still it's illuminating. In terms of future plans for participating in VBP, 82 providers responded to this, and only 2 of those said that they plan to decrease participation in VBP. Most either plan to stay where they're at or increase slightly. We asked about role clarity. This is something we're hearing about a lot more in stakeholder conversations and some work with some contractors who have communicated with ACHs and providers and our managed care organizations. And I think this really highlights that we have a lot of work to do in terms of role clarity. Only 7 respondents said that roles are very clear or extremely clear, a lot of somewhats and not so clear, and 18 not clear at all, which is 18 too many. So definitely some work we can do to improve this area, which I'm sure will have downstream effects on readiness and comfortability with VBP and things like that. So just pulling together some summary findings. Experience has generally been positive among providers with some degree of VBP participation. We're still seeing a lot of providers that are lagging behind in participating in VBP, at least according to the survey. Most providers that respond to the question do plan to increase participation in VBP or stay the same, but technical support in this area is highly desirable. Lack of interoperable data systems remains the top barrier. That's consistent from last year. And some items we've identified that we can focus on to facilitate adoption of VBP and participation in this transformation is improving the timeliness and comprehensiveness of data shared to providers, and this needs to happen on a multi-payer level. There needs to be broad investment in interoperable data systems. We need to do well to align quality measures and incentives. This also needs to happen across payers. State, we've implemented quality measures and contracts with the assumption that a lot of that would trickle down to MCO provider contracts, but and from our conversations with the plans, that has happened to a significant deal or a significant level, but would be interested to hear from providers themselves and from the MCOs some opportunities for more alignment in that area. And then we need to foster collaborative and trusting relationships. I think this happens in meetings like this where a variety of stakeholders and partners come together to have real conversations and talk about what's going on the ground. And then identify technical support and connect providers to that technical support. One thing we learned this year in some conversations one-on-one with ACHs and providers that the most valuable technical support is that which happens at the clinic level on a one-on-one kind of practice coaching type support. And so, the Healthcare Authority doesn't have a lot of resources at the moment to throw into this, but we have been able to compile a list of good technical support resources and would be happy to work with ACHs and providers with identifying the most impactful resources and strategically deploying those among participating providers. And then doing what we can to improve role clarity. And that's a pretty general statement with, it's not a real actionable thing there because we have to decide how we're going to do that. But I think it starts with conversation and being clear and speaking in real terms about with real guardrails for who's doing what and where their role ends. So that's all I had. I did include an appendix of sorts with some information just on general categories and then a list of measures that are in the demonstration toolkit. So you'll have those to reference if you're interested. But now I think we have some time for discussion, if that works for folks.
So thank you, JD. I think we'll go ahead and open it up for questions, but one of the things I was really excited to see was the slide that defines the roles between the MCOs, the ACHs, and the Healthcare Authority. I think that this has been kind of a sticking point in understanding where we're supposed to be at. So I would like for you just to kick us off with some of the questions. Is that you had said that one of the roles of the ACHs was to support VBP enabling clinic transformation. Could you describe what that might look like, JD?
Sure. So one of the things that, I mean, we did this a lot through the State Innovation Model grant with Qualis, I believe is now Comagine, you know, identifying participating providers and deploying kind of one-on-one practice coaching where, and it can take a variety of, it can look different in different scenarios depending on what provider needs are, but it can cover things like helping them understand how to bill more effectively, if there are things that they are being incentivized for through contracts that require them to be a little more intentional about billing, or if there are kind of care coordination best practices that they need to learn, things like that. So a lot of this kind of one-on-one practice coaching is what we've identified as the most valuable. And we see the ACHs could play a key role in connecting providers to that and potentially deploying resources through the Medicaid transformation to that end, to either contract with those practice coaches or, you know, provide some kind of mini grant for clinicians to participate in those activities. I'm not the clinical practice transformation expert, so that's kind of the best detail I have. But we do still have the, it's not the practice transformation support hub anymore. It's like the care collaboration portal or something. I should know the name of it. I apologize for not, but there is still an online portal resource that has a lot of useful information. We also have some resources that we can share that kind of provide a starting point to identify some potential resources, but it's really going to be up to those local providers and potentially ACHs to identify those areas that you know, you want to support financially. And you know, some of these things can be done collectively. You know, I know that some happen, you know, like a classroom setting on a Saturday that walk a group of providers through some concepts, so that's an option as well. Is that answering your question?
It does. That's very helpful. If you were sitting where I was sitting, you would see a lot of smiling faces in the front row. Our practice transformation team does provide one-on-one technical assistance for clinical transformation. So we're glad to know that we're on the right track, which leads me to my second question. Why did the Healthcare Authority include the 2 questions about PCMH?
That's a good question. So in a lot of our contracts, especially on the commercial side, for example, our accountable care program, which is our ACO model for public employees, we actually require participating providers to follow PCMH. And so it was more a curiosity. I don't think we have plans at the moment to institute any kind of broad requirement around that. I think it was more curiosity to see if folks are following that. And we had heard kind of through the grapevine that there was a lot of burden that goes along with achieving certification. So kind of a point of curiosity that if that's a barrier, is it a barrier? And then is there still interest in following PCMH even though if there's not official certification? And I think from what we saw just from those 2 questions, the answer would be yes.
Great, thank you. I just want to make one more comment too about one of the roles of the MCOs is providing timely and actionable data to providers. I think we hear a lot from the provider offices that that's a gap, and so I was just wondering. And we'll probably address this question when we have the MCO panel come up at a little bit later time. What is the Healthcare Authority doing then, or is that all coming from claims data?
Well, I'd say it's a mix. The MCOs certainly have a big role to play there, especially when it comes to their contracts and individual contracts with providers. We are trying to emphasize and build out the clinical data repository. I know that for some providers there's an administrative burden to get their EMR synced up with the CDR, but I think there's a lot of potential there, and that would mostly be, it is being backfilled with claims data, claims and encounter data, but if it's propagated in the way that we hope, it would be filled with a lot of clinical data from EMRs. So I think there's a two-sided approach to that. We have, I don't know that we have the magic bullet for this. We know that patient attribution is a big challenge, and MCOs do assign Apple Health clients to providers, but that doesn't necessarily dictate that patient will see that provider. So we're very curious to learn more about how MCOs respond to providers that see patients that aren't assigned to them, primary care providers that see patients that aren't assigned to them, how often those assignment roles are updated according with that feedback, and then how closely that assignment tracks with some type of attribution model. So we've actually been spending 7 or 8 months here at the Healthcare Authority trying to develop some kind of standard attribution model for the agency, not necessarily something that we would enforce through the managed care contracts, but just another tool that we would have. And one thing we want to look at is how closely that attribution model, once it's developed, will track with the assignment level files for the MCOs, because I think that's a source of confusion too. And not the fault of the plans or providers involved, just I think a nature of the system.
Got it. Thank you, JD. Well, audience, does anybody want to kick us off? Yes, Chuck. Yeah. We're passing the microphone around.
Okay.
This is Chuck Eaton. I want to thank you for the organization of the material that you brought, because it allows us to go stepwise down to fairly concrete focuses, and that's what I'll try to do. In your summary, you had a topic that you will be following of aligning quality measures and incentives. And the general area is the behavioral health integration into physical health care. So we have had considerable discussion about providing integrated behavioral health with providers trained to address both mental health and substance use issues. But when we get to your quality improvement measures, we're no longer talking about behavioral health, and among the common measures are measures of addressing mental health. There are the measures. There are questions addressing substance.
Sorry, Chuck, I think someone on the line has put us on hold. Oh, there we go. Although I do appreciate a nice viola.
So let me start at the end. In your quality improvement measures focus, behavioral health is no longer the explicit topic, but mental health and substance abuse are separated in common measures or specific measures. So you're asking providers to keep them separate so they can report on them, where our goal is to help them learn to provide integrated care by providers trained in both.
Do you have a response to that?
Well, let me try to restate it to see if I understand where you're coming from. So the idea that we're sort of parsing out behavioral health and focusing more on substance use and mental health in the quality measures is kind of leaving behind the providers that are doing a lot of behavioral health services. Is that the contention there? Am I?
Ruben, can you give him back that?
Our history is that mental health services and substance use services have been separate. The whole movement in behavioral health is to integrate them, ultimately to train providers who can provide both mental health services and substance use services, because most of the individuals have both issues. So that is our goal, but you're asking people to separate the issues in terms of quality assurance measures.
I'm not sure I follow what you mean by separate them, because we're tracking both substance use and mental health. I mean,
in the slide that you showed about quality improvement measures, there were several, and among the common measures was mental health, and among the specific measures was substance use.
Yeah, so good question. If you look at the substance use measure, it is one of the MCO specific measures, but we've decided to put those in each MCO contract. So all 5 MCOs will have both substance use and mental health measures.
But
The only one. I'm sorry?
How can you measure them separately if they're integrated?
That would be a question for someone that knows more about how these measures are reported through the data. I unfortunately don't have the expertise to answer that, how they would be reported separately.
Well, I think it relates to the claims data.
Yeah.
Some of the measurements we're looking at are specific. For example, increasing the substance use rate. You're looking at claims for the initial intake and claims for the follow-up routine care. And so through the claims data, I think you'll see where some of those can be measured, even though the practice philosophy is integrated care, getting the right service at the right time and the right place.
Does that help, Chuck? Kat?
Kat from CHW, and this may not answer your question, but in just thinking, I mean, I think as we move forward, the idea may be that as we are striving towards integration, one of the goals is also thinking about how different providers that are providing services that may be integrated, how are we looking at the measurement across that provider to see how if it's a provider that has integrated mental health and substance use together, how are they being tracked along those two measures? And similarly, as we're starting to move to a space of really wanting to have primary care services as well within that space, you know, how are we again tracking these measures collectively to show are those services actively being integrated for that individual in a one location, or at least co-located across different service sites?
Any other questions for JD? Diane?
There were a couple of, oh, go ahead.
So, from your perspective, from the ACH perspective, what is the ACH doing well, and what is something that the ACH could improve upon?
Sure. So, and I'll say this with the caveat that we haven't gone through or finished the review of the third round of semi-annual reports, so I haven't pulled any takeaways from that, which is where we get a lot of this type of information. But in general, we're very pleased with how the survey is being promoted. You know, we've seen significant improvement and increase in provider participation. So that's a big credit to the ACH. So much appreciated there. One of the things we hear repeatedly is that behavioral health providers need to be brought into the fold to a greater degree, so to speak. So anything the ACH can do to bridge those relationships between managed care organizations and behavioral health providers, even physical health providers and behavioral health providers, to facilitate those relationships and understanding of expectations and payment models, what have you. Anything to make those behavioral health providers more comfortable with the changes that are coming down would be of great help. Some best practices we've identified from, and this is mostly pulled from previous semi-annual reports, is that supporting in-person technical assistance at the clinic level is considered a best practice and something we would like to see more of. When there are needs assessments conducted to providers, to then directly identify technical support that can address those needs that are identified through that assessment. And I do wonder if there are opportunities for joint purchasing of whether technical support or even information infrastructure across ACHs and across providers, and something that ACHs could facilitate that conversation. So I wonder if Greater Columbia, given the geographic reach of your region, that might be something to consider, that if that's an opportunity you could facilitate among your providers. Now that's a big conversation and a big task, so just an idea. And we have seen ACHs do a very good job of directly incentivizing providers to participate in projects or things like the survey that directly relate to Medicaid transformation goals. So everything that can really tie back to what's laid out in the transformation and in the MCO contracts, I think will serve to address some of those challenges of aligning expectations and quality measures and things like that. And then I think we could stand to have a group conversation about how to better clarify our respective roles. I think in some cases, not in Greater Columbia's case, but in other ACHs, there's been confusion, at least from what we've seen in the semi-annual reports, about getting in the mix of contracting, ACHs getting involved in contract terms or negotiations, and that's certainly not something we want to see. And I think we've addressed those, but that just speaks to the broader idea that there is a lot of work to be done in terms of clarifying respective roles. And I think that's a group conversation and group work that needs to happen with all of us. But I think, doing things like these learning collaboratives and bringing folks together to have conversations, I think that's a key role for the ACH, and so I applaud you for doing these.
Any other questions for JD before he takes off? Last chance. Sure. No burning questions right here. Got the expert on the phone. Well, JD, we just wanted to thank you for. Oh, here's a question. Yeah, Ronnie.
I'm going to perspective though, it's from the consumer perspective. So integration is going along just fine, but at the consumer level, I'm finding that the MCCO, I'm having difficulty accessing certain benefits. And so I'm just wondering, because I know that my provider is trying to provide me with this integration type of service, and I know that they're doing a good job because they are supporting me. The issue that I'm finding with other consumers and myself are getting the services approved through the MCO. Where's the accountability in that?
Well, that's a good question. I mean, the accountability runs through HCA, right? Like we have the terms with the managed care plans, and we are requiring that they provide these benefits to their clients across the board. So if those aren't being met, I mean, that accountability ultimately runs through HCA. There are, we have contract management processes through which to hold plans accountable. There are performance aspects that they have to meet. I don't know the details around whether or not we audit those practices. We audit the deployment of benefits and delivery of benefits to clients. This might be, I think it's kind of a new world with the integration, and probably MCOs are learning how to handle it, as well as, the providers and the healthcare authority for that matter. So I think that those cases would need to be taken up with the contract management side of the house, which I'm not directly involved with, but ultimately that accountability, runs through the healthcare authority because we manage those contracts.
Thanks for that honest answer, JD. I think all of us are trying to work valiantly together on solving some of these gaps in services and care, and I just wanted to thank you from Greater Columbia ACH for taking time to talk with us this morning, and if we could all give JD a round of applause.
Well, thank you very much. I appreciate the opportunity, and don't hesitate to reach out with questions via email or give me a call.
We will make your PowerPoint slides available on our website, so for those of you that asked that question in the chat box, you'll be able to find those probably this afternoon, the slide deck. We are going to transition now. Take a big breath. We have a panel of MCOs, and I'm going to ask them to come up. Courtney Ward from AmeriGroup, Kat Latte from CHPW, Ruth Bush from Coordinated Care, and Kaylee Freshne. Did I say that correctly? From Molina. And while I am asking them to come up, I think that there was somebody from Molina that was going to take this opportunity to talk a little bit about the Innovation Health Fund. You'll be receiving a very exciting announcement that is available to our providers. I think it's $1 million over the course of the next year that we can apply for certain services that are delivered through our behavioral health and our integrated managed care providers. Is there somebody from Molina that was going to talk about that?
I think Jorge Rivera was going to take that.
Oh, Jorge, do you want to talk a little bit about that?
Absolutely. Carol, can you hear me?
Yes.
Well, Carol, thank you for the opportunity to share with everybody, and my apologies for not being able to attend this month's meeting in person. Basically, what we are communicating today and this week in general is that starting this coming Tuesday, we will open applications for what we call the Molina Community Innovation Fund. This is 3 years worth of $1 million funding, so a total of $3 million that Molina is trying to put in the community, specifically for programs that are delivered by organizations that are supporting the integration of managed care in the state. So this is the main idea here is that we all understand the managed care organizations cover benefits that are contracted with the healthcare authority, but there's always gaps surrounding this work on services that help the outcomes of physical health, behavioral health that are not quite covered benefits. So we are encouraging organizations that have programs that can contribute to those, and there's a number of specifics that we want to share regarding the kind of project that can be applied. Basically, it will be $1 million for the first year. This is the first year. Organizations eligible will be organizations that are already into integrated managed care. So all of Greater Columbia is eligible already. Every organization in the Greater Columbia area is eligible. It will be for organizations that are 501c3s, so nonprofit organizations of any kind. And basically what we are looking for is for ideas that are helping move forward the topics that help healthcare, specifically decreasing barriers to access, addressing social determinants of health, or growing integrated care services. What we are expecting is that many organizations will apply. We are going to basically award a number of grants of 2 different categories. We call it a catalyzer grant. Will be $10,000 to $20,000 per grant. The transformational grants will be about $100,000 per grant, and we are taking applications starting Tuesday. At the end of October, we will be announcing the winners. We have a number of Molina leadership from different departments that will be assessing the proposals, and there's an advisory board that will be working on the selection of the proposals. So basically, it's 2 kinds of grants. Let's call small and medium-sized grants, anywhere between $10,000 and $20,000 are small grants. Anywhere between $50,000 to $100,000 would be the medium, larger ones. We would hope that people start applying on September 24. Applications close in October 18, and we have a number of a couple of documents that I shared with Carol. Carol, feel free to share them. Of course, most of you know me, so if you want to connect with me directly, I'd be happy to send you the information. Again, we're talking about 2 different kinds of grants, and this would be the first year of application. Next year will be the second round, and in 2021 will be our third round. As I said, the main goal here is to benefit Medicaid beneficiaries in integrated managed care with programs that are not currently covered by Medicaid benefits. And with that, I can take quickly questions, Carol, depending on the time we have.
There's a question from Penny.
Is there a reason it's only available for nonprofits when a lot of us for-profits serve the Molina population?
Did you say that? Is there a reason it's for nonprofits only when there's a large majority of providers that are for-profit?
Well, I guess the reason is that most of the time, the organizations that are for-profit are working directly with managed care organizations and direct delivery services in many of these programs. The organizations that struggle more to connect with funding are the organizations that are defined as nonprofit. So we thought, and what we have seen across the state is that the organizations that need more funding that are not covered by covered benefits from the healthcare authority under Medicaid are usually nonprofit. So we wanted to help those organizations that are usually the ones who struggle to find the funding.
You're not able to use these dollars for agencies that are serving your enrollees. I just want to make sure you understand, these monies can't go to the enrollees we serve for profit.
So I guess the question, Jorge, is that we're eliminating a large group of providers that are providing services to your enrollees. So I think that there was concern about the fact that there is a kind of a disparity there.
Well, you could say there's a disparity from that angle, but at the same time, most of the organizations that contract with Molina and their for-profit organizations, we have agreements on well, just to give you an example, on value-based care, and we have a number of agreements on covered services. So precisely what we're trying to cover is the things that are not currently covered services, and that we have found across the state that they're usually services that are provided for smaller organizations, usually nonprofits, who have not been able to enter the sometimes rather complicated system of billing Medicaid directly.
Well, we are not going to rewrite your Innovation Health Fund policies right now. So I think that, thank you for that opportunity. Everybody that received the packet this morning, you should have that information. We will also be sending out an email blast to everyone for access. Jorge, was there a special application that's tied to that, or is it just kind of is there a link to your application?
Can you ask the question again, Carol? I didn't understand it. Sorry.
The application that you fill out.
Yes, it is a very simple online application process. So if you go online on Tuesday, September 24, and the URL is there, it's Molina Healthcare / Molina Fund. You will find a button to start the application process, and there will be a few very basic questions to answer right there, and you will be able to upload the full application document. So the process is very easy. The documentation includes a Q&A, and we will be taking questions from anybody through our community engagement and our different teams that are trained for this. So it shouldn't be too hard. And please ask questions, connect with me directly if you have questions about how to apply.
Great, thanks, Jorge. Well, I get to hand over the mic now to Sam Wardell. This is really part of a learning collaborative, and Sam is our Director of Practice Transformation. I think what she's going to do is ask all of our MCOs to self-introduce. But again, I wanted to remind everybody on the phone that if you're attending this, make sure that you put your name in the chat box, or if you're attending in person, make sure that you signed up on the sheet so that we can give you credit for your attendance today. Thank you.
Thank you, Carol. First and foremost, I think we need to start around the room, and then we will go to the phone just to make sure that they know who their audience is here. So if we want to start, and if I can get someone to help me with the microphone to go around the room, I appreciate that.
Good morning, Jenna Shelton, Greater Columbia ACH.
Okay, Sanchez, from GCACH,
And can you say your role with the organization as well, please?
Practice Transformation Navigator.
My name is Rachel Guest, and I am the Finance and Contracts Coordinator with Greater Columbia ACH.
Ruben Peralta, I'm the Community and Tribal Engagement Specialist.
Becky Holm, I'm the Director of Finance and Contracts with GCACH.
Michelle Sullivan, Quality Improvement Director at Yakima Neighborhood Health. Good morning, I'm Lisa Hafner, I'm the Nursing Director at Yakima Neighborhood Health.
Hi, I'm Diane Campos, Yakima Neighborhood Health Services, and I am the Care Coordination Supervisor.
Jocelyn Pedrosa, I'm the CMO at Yakima Neighborhood Health.
I'm Mike Maples, representing Community Health for Central Washington. I'm the outgoing CEO.
Senior Director with Comprehensive Healthcare, Senior Director.
Giuliani, CFO, Comprehensive Healthcare.
Deborah Cadleg, Population Health Coordinator.
Practice Development Manager, John Christensen, Community Volunteer.
Sandra Forrest, Planning and Development Senior Manager at Yakima Valley Farm Workers Clinic, and I also represent FQHC on the governing board.
Andy Keppel, Associate District Director of Community Services, Tri-City.
Quality Improvement and Sean Banner, Lord Medical Center, HR Compliance Program Coordinator. Good morning, Jenny Bryland, I'm resident pickle and local Lord. Dina Otis, Executive Director of Behavioral Health for Lord. Good morning, Barbara Lee, Lord.
Ed Barber, Comprehensive Healthcare, Chief Administrative Officer.
Robin Appling, Administrator at Women's Services at Triumph Training.
Teresa Atkinson, Clinical Supervisor for Women's Services at Triumph Treatment Services.
Susan Campbell, and then CBT is volunteer position.
Martha Landman, Columbia County and Garfield County Public Health.
Sue Cheddar, consultant with Foster Memorial Health. Good morning, Lisa Gonzalez with Benton Franklin Health District, Community Health Worker and Program Coordinator. Haley Middleton, CPHA Quality Manager. Rodriguez, Care Coordination Manager at CPHA. Nicole Harris, Catholic Charities, Director of Healthcare Transformation.
Chris Dehone, Head Imagineer at Catholic Charities.
Jamie Carson, Executive Director at Somerset Counseling Center. Sarah Clark, Director of First Step.
Penny Bell, Administrator, Fragile Balance.
Pat Flores, Program Manager of Serving. Flores, District Supervisor. Juan Valdez, Clinical Supervisor.
Donna Albaytero, Regional Director of Operations with Chaz Health.
Marissa Engels, Coordinated Care. Amelia Davis, Coordinated Care.
Beth Johnson, CEO, Coordinated Care.
Casey Dodson, with Catholic, and the Care Management Coordinator.
Care Coordination Manager.
Dr. Gonzalez, GCACH, Director of Behavioral Medicine. John Delegowski, Best Franklin Health District.
Ashley Bryden, Vice President of Ideal Options. Nick Cruz with Catholic, Care Management Coordinator. Rio, I'm with Catholic.
Joel Chavez, Regional Manager for GCACH.
And I'm Wes Lucky. I'm the Deputy Director for the Greater Columbia ACH. Thank you all.
Lauren Johnson, I'm with Greater Columbia ACH.
Chelsea Chapman with Greater Columbia ACH.
And at this time, we'll go to the phone. If you'll start with your role and your title, or I'm sorry, your title and your name and what organization you're with, we'd appreciate it.
This is Sarah Avan. I'm a practice administrator with Cadlic.
Kevin Martin, Chief Medical Officer, Kittitas Valley Healthcare.
Amy Larson, Regional Deputy Medical Director with Chaz Health.
Lisa Quaid, Administrator, Police Medical.
TJ Osborne,
Edie
Police
Dibble.
Medical.
Tim Nygren, Police Medical.
Edie Dibble, Senior Director of Contracting and Network, Coordinated Care.
Judy Miller, Clinical Director, Columbia County Health System.
Liz Rice, Director of Quality, Tri-State Community Health.
Jean Murrow, Board President and Volunteer at Family Learning Center.
Paula Zapata, Quality Manager, Program Manager at Molina Healthcare.
Amy Norton, ESD 105 School Nurse Corps Coordinator.
And Beck Kuhn, Behavioral Health Operations Manager, Yakima Valley Farm Workers Clinic.
Katie Zorba, Community Health Worker with Community Health Plan of Washington.
Lisa Pallas, Care Coordination Manager with the Yakima Valley Farm Workers.
Lindsay Ng, Executive Director of the Health Center in Walla.
Mandy Olson, Director of Quality and Risk Management at Kittitas Valley Healthcare.
Anyone else on the phone?
Kirk Williamson, Benton Franklin Community Health Alliance.
Berta Lopez, Virginia Mason Memorial. Angelica Vasquez, Client Services Division Manager, Catholic Charities. Ashley Walker, Police Medical.
Anyone else? Okay, just a reminder that if you're on the phone and you're a caller, in the chat box to make sure that you type in your name so that we can record that as well. At this time, I'd like to also have the MCOs introduce themselves.
I'm Kaylee Dufresne. I am a Director of Contracting with Molina. I think your packet says that I cover the Greater Columbia region. My partner, Heidi Nelson, actually covers the region, but she's universally recognized to be a way superior person than I am, so you guys are in luck. But I think my contact information is in there. We'll always get your request to the right place.
Hi there, Megan Gillis, Integrated Managed Care Program Director with Molina Healthcare.
Courtney Ward, Strategy and Finance Manager with American Washington.
Ruth Bush with Coordinated Care, and Chris, I'm really tempted to use your title, Imagineers, but I'm our Senior Director of Healthcare Operations.
Shelly Mata. Hi, this is Shelly Mata, Pediatrics for You, and the Clinic Manager.
Thank you.
So, Kat Latay, Community Health Plan Director of Health Innovation, and one of the best titles I heard just recently is that Alphabet, Google operator, they have a moonshot director. So it's got big presence. I love that.
So to start with, the MCOs have asked us to actually get a lay of the land. Oh, okay, can you also take this and I'll talk into this one, please? So the MCOs have asked us to ask the audience to get a lay of the land of what their definition of value-based payment is. Can we get some volunteers to give some definitions in the audience, please? Don't be shy, raise your hand. I'm gonna start picking on people.
Simple version, pay for performance.
Right here, Martine.
This is Jamie from Summerside. My recognition of it is it's payment based on quality of service that's meeting measurable objectives so that we can show the patients are getting full spectrum of care versus just throwing money based on numbers of patients. They had nodding, so I'm guessing.
Anyone else?
I would just like to add that it's evidence-based care that's given to the patient.
Contracting model where there's shared risk and shared reward.
What does practice transformation mean to you? Can we get some audience participation with that? Thanks, Jamie.
For me, it means Jenna coming to my office frequently, and answering all my emails about bidirectional care and different ways to start adding measurable outcomes that will set us up for success with the value-based purchasing arrangement. Mostly to me, it just means Jenna.
Barbara?
So for me, the most important words when I think about patient-centered medical home is that the patient really is the center of care. It's evidence-based care, it's integrated care. Those are the words that come to my mind.
To me, practice transformation is transforming the way we deliver healthcare from a sick care system to a healthcare system, in its simplest terms.
Do we think that culture plays a significant role in the practice transformation? company, staff, organizational? Anyone want to answer that? Do we think that culture plays a big significant part in culture change for participation in practice transformation?
I'll say yes. I've heard from several providers that it's difficult to make changes because we've always done it this way. We've always did this and this happened. So I think it's a huge culture change for the majority of providers. You know, we look at things like residential treatment where it was, I don't want to say automatically a 30-day stay, but now it's more, we've got to review it every either 7 days, 14 days, something I had to do before. I think there's a lot of benefits to it. I think there's a lot of shock for some people that we've not, the state has constantly tried to give us to measure success, and they've given us the silliest things to measure. One of them was you have one contact per client each month for 3 months in a row, success. It doesn't matter if you're still using it, it was if you have a contact. They know that didn't work. What's another measure they did? Oh, decrease the level of care. So if they were in intensive outpatient level 2-1 and they transferred to level 1 in your facility, you discharge them from 2.1 and reintensive to 1, and that was success. So I think that's been hard. So I enjoy the fact that we're going to have some outcome measures that directly tie to the outcomes of the patient, not the outcomes of us. I think we've been measured, but now we can measure patient success. Or patient health, I should say.
Thank you, Penny. Anyone else? Barbara?
I think most healthcare providers, at least we're trained to live in silos. That's how our training was, whether it's physicians or nursing or even social work. We live in silos, and they don't really attend to this concept of integration. So that, to me, is a big culture change. Plus administration, I think, lives in silos. Talk about cost reports and how finances are developed. Those are all silos. And so when we think about integration, that's a huge difference, I think.
I'm going to ask the MCOs, what does practice transformation mean to you? Want to start?
Sure. What does practice transformation mean to me? So I think it means learning first and foremost. I think we all have a grand vision for value-based payments and for practice transformation and what that means, but I think figuring out how to get from point A to what we have learned is point Z is the hardest part. So right now, I think transformation means a lot of meetings and a lot of conversations, but it really is about that learning and figuring out how to use data effectively, how to communicate data effectively, how to get that information to the places that it needs to go.
So I think practice transformation is a big culture shift on the MCO sector as well. I mean, this is a different line of business in the state of Washington, and for those companies, MCOs that have a parent national company, Washington is far ahead of some of what other states have done. So it is really much about the same thing Melina said. It's a lot of meetings, it's a lot of conversations, it's a lot of brainstorming, it's a lot of trying to be flexible, trying to understand the system, and to really see what fits in as appropriate and is least burdensome to the provider network as well as to the member themselves.
Yeah, I think what you all didn't know is you're the panel as well today. So you offer some amazing definitions that I don't know that I have the magic bullet, but it really, I think, what I can add is there's no end point to practice transformation. The more we know, the more we want to get better at taking care of individuals in our communities. And so it's about aligning our practices with evidence
services and aligning our practices for what costs less, aligning our practices with what takes care of individuals.
The root, because the core is, there we go. So I would agree with most of what has been said. I mean, really, it's a journey. It's not a destination. It's really about how are you evolving your practice to move towards a space of serving and caring for an individual and supporting that individual to an improved health outcomes, sort of moving them along that path, helping them get on that path to better health. I think the question related to culture is really critical. It is a huge culture change for an organization to move into this space. It's about being honest with yourselves and with us and with each other about sort of where our strengths and what our gaps within the work that's moving forward. And again, just it's all about sort of focusing on how the individual and the family are receiving the best care possible. So that's how I would define that.
Can I get a show of hands in the audience of who is actually contracted in a value-based payment contract?
Based off the introductions, there should be more.
I know. For those on the line, if you have any questions or comments, can you please put them in the chat box and we will repeat those here in the audience.
I guess in response to that question, though, I think that's a really good point, because I think that the idea of culture change with respect to the direction of value-based payment is really just a means to hopefully support practice transformation and support better care for an individual, creating more flexibility. But individuals who are in this room may or may not know that the organization itself is in a value-based payment arrangement. So the idea of what that culture change means and why is also important as we think about the way in which an organization has to change, and that idea of how it can't just be within the administration potentially of that awareness of that arrangement, but it really has to cascade across and downward through the organization itself to understand sort of what are those goals collectively. So to Ruth's point, it's probably more people should be raising their hands, but recognizing that some folks might not know that that is actually the case.
It also depends on which draft of the contract we're looking at. And we have 9 different contracts. So current draft, we have some value-based services.
Any other comments on that? I want to ask a question that isn't on my list of questions. How important is leadership to practice transformation change and value-based payments?
How important is leadership? Is that what you said?
We have a lot of leadership in this room today.
No, I think it's crucial. There's no, in terms of, you asked a question about kind of practice culture, and culture is set by leadership, and so if leadership does not buy into the concept of practice transformation or value-based purchasing, it's difficult to make any progress. So for leaders in the room, thanks for being here and committing to the concept.
Just echo that. I guess the other question is, I think we heard from folks in the room about the importance of culture, and so those that have, again, you guys are part of the panel. For those of you that have moved through this process, what have you found as helpful as leaders in moving this change forward? What about that leadership within committing to practice transformation, committing to change, has been critical for your organization?
Well, for me, it's not just the leadership in our agency, it's the leadership in the agencies that we're collaborating with, and just having really good communication with partners, where we're willing to just throw ideas out and see what kind of care we can provide together, and then from there, having that open communication with staff about what that looks like in real life. I don't know about anybody else, but I try not to
flood my clinicians with stuff that they don't actually need to know for their real life. And so it just helps them to focus on what that looks like clinically, and then with my admin staff, what that's going to look like on the business end, like reporting the measures, things like that. So I think leadership is really critical too in delegating the information appropriately.
Yeah, Jamie, a follow-up on that, I think, would, when you looked at JD's presentation of where clinics are on SAMHSA's clinical integration pathway, so many are just in kind of the collaboration with the different agencies. And if you're not already to that, North Star 6th level of fully integrated within your own clinic, you've got to have partners to achieve this. And so it's finding like-minded leaders at a practice that provides physical health, or in your case, maybe mental health, because you're trying to integrate, and it's about finding leaders that share your values to do that.
I would just add that I think it's critical that, leadership really, I think data is an essential part of this process, right? And it's critical that leaders understand where the bulk of their data or the importance of their data lies, and how to structure value-based payment arrangements or quality improvements around that data. And then, trickle that down through staff as appropriate, and really take that as the core focus in how you're moving quality care within your organization.
Can you give us some examples of what data they might be able to look at for value-based purchasing?
Well, I think, the HEDIS measures that JD provided, the ones that are in MCO contracts, I think the NPP P4P are essential ones as well. There's no lack of data, right? There's no lack of data, and it's really I think the thing that I struggle with the most is MCOs can tell you about their membership, and there's certain pockets of those memberships of where we want to focus on, but that may not be attributable to your specific organization, and that's okay. So if you have a pocket of, AmeriGroup membership, for example, and you're seeing a trend, or you're seeing where quality improvement can occur with that population, we're open to having those, organizations approach us in regards to how we do that. So it's very, it's not black and white in regards to data. It's very, collaborative, and it's meant to be that way. So we truly know how to work best with each organization and not push something that's not applicable.
Yeah. Also, calling back to JD's presentation, in the provider survey, it said the number one thing providers needed was timely and actionable data to move forward. And really kind of want to acknowledge we've got a mix of FQHCs, community health centers, behavioral health providers. I think MCO has done a really good job at sharing with FQs and community health centers. Our quality team works with a number of the community health center quality teams on a regular basis to exchange patient data. I think we can improve in sharing data with behavioral health providers, and it's something we're committed to, but there are some challenges. And JD also mentioned that attribution is one of the bigger challenges. We do primary care attribution, and because of that are able to share patient level data. When it comes to behavioral health providers, we don't have a way to attribute a population to you, and so there's that just natural barrier. And I don't think we have the first, the best answer, but I would love that. That's a collaborative relationship, I think, in conversation with behavioral health providers to try and figure out how to do that. In some counties, it's easy because there are some providers that take care of a single county, and so that data sharing is a little bit easier. But in places like Tri-Cities and Yakima, where there are multiple providers in the mix, how do we know what patients are being served by what providers in a way that we can compliantly share data? We want to do it, though. You've got our commitment to figure out how to do it. I think there's just some challenges that we have to overcome together.
Yeah, and building on that, I think the other component too is getting back to Jamie's point a little bit related to relationship building and partnership across providers, because we are committed to trying to address that challenge around bringing forward more actionable data with behavioral health providers and with other providers as well. But the idea of how organizations can partner, that can actually be a first step because there's an idea of how you all might be able to share data together. And that facilitation can potentially be helped or amplified by the plan, partnering and saying, here's the data that we have, and then here's the collective data that you all have. You all share members, right? How do we work together within sharing data related to those individuals that you all mutually serve, or that we all mutually serve? But I think it is something that we are working on, and I think my colleagues really address some of the issues.
Hi. This is Paula Zapata, and I am actually part of the panel representing Molina's quality department. I apologize that I was not able to be there in person. I just wanted to add one more thing on what data would be helpful in negotiating VBP contracts. I think it's also understanding the capabilities of each entity, so not just the MCO's capabilities, but as well as the provider's capabilities. For instance, what information can they provide to us? Coding capabilities, any data exchange, supplemental data feeds. Is that something possible? I think that would also be very helpful in determining what specific quality metrics could be part of a future contract. And like someone had mentioned earlier as well, just trying to determine member attributions and making sure that we, as MCOs, we have the most up-to-date information for provider rosters, as well as we are very transparent with the provider groups on who we currently have assigned, which patients are assigned to them.
So I would echo all of that, but I want to go back to the practice transformation idea, because I think in our experience, and I'm sure you all have experiences too, we share a lot of data and we have a lot of VBC relationships, but then, I think this is a really great learning where, I think Ruth, you said this, that based on the folks in the room, you'd expect a lot more hands to go up based on who is in a VBC. We experience that too, and even more. We send, a ton of data to providers, and they often say, well, we don't know anything about our population. You don't give us any information. And that's not because they don't have the infrastructure or because the way that we send it is, in special coding or something. It's just in an Excel format. But being able to work together to figure out how to make that data most usable, and not just in the way that we present it to you, but in figuring out how you can put that into your EMR or into your practice workflows that makes it most useful. So even though maybe your physicians or clinicians don't need to know that you have a value-based relationship, but they then know what the actionable item is for them on these patients as they take them into the rooms, as they have their conversations, as they do their behavioral health screenings. So that's, I think, a challenge that we're really trying to address right now, and we're taking the lead from a lot of our provider partners that have figured out how to do that way better than we could.
Can you give us some examples of what innovative contracts might look like for value-based?
That is a difficult one, and it's really it's something proprietary too to each MCO, so I'm not really sure how comfortable we are with sharing examples, but we're always open to having one-on-one conversations about those. I mean, for America specifically, you all have an assigned contractor. That is a fluid conversation you can have with them, and so we do have an open door policy about sharing, what some of those would look like for America.
I think another space I would really like to echo that, the open door conversation and sort of coming forward with ideas. That idea of that piece that came forward in the survey related to one of the areas that is really accelerating value-based payment and accelerating improved care is trusted partnerships and collaboration. And so that idea of moving into a space of trusted partnerships and collaboration, how do you set up really regular meetings, look through what are those milestones that you want to achieve to get to a place or get to a goal to have a value-based payment arrangement. That may not be a realistic next step, but what are the steps that you all need to take collaboratively with managed care to move into that place? And I think the other place to look is there's a lot of great resources out there that have examples of contracts that have been built nationally. So through the Healthcare Payment and Learning Action Network, there's a lot of examples out there around model contracts that may be able to bring forward ideas for folks that are maybe wondering what this might look like if you maybe don't want to enter into that conversation immediately with the managed care organization. And the other place too is within that healthcare payment and learning action network. It at least starts to set forth what are the types of contracts that would meet those expectations. And I always want to emphasize that while the state is really highlighting the goal of being at 2C, which is a pay-for-performance arrangement on top of fee-for-service or higher, there are critical steps that organizations need to move through to even get to a place to effectively engage in a pay-for-performance contract. So the idea of thinking about what is happening within the 2A or 2B category, which is around paying for reporting and paying for infrastructure, to be able to think about what does that look like so that you can move into that space of a more advanced arrangement. And so I think just recognizing what that framework is around the Learning Action Network, and that it's not a continuum. It doesn't necessarily mean that everybody needs to be in a population-based total cost of care arrangement. That might not be the best space for someone to be ever. But that is really is a framework. It's not necessarily a continuum in getting to the furthest side on that framework.
Yeah, I'm going to piggyback a little bit on that. And I would agree, it would be hard for us to share a kind of innovative playbook, but would love to have individual conversations. But maybe an unpopular opinion, but sometimes we have to take steps backwards, as Kat was saying, in order to get to innovation. I'm going to speak particularly to behavioral health providers. That's most of what my experience has been. And we didn't get a lot of great data from DHOs in the transition that would allow us to immediately enter into VPPs. And I think that you might have conversations where we need to move someone to fee for service so we can get some data that we can actually build an agreement off of that will eventually pay for performance and pay for value. And so, we've kind of heard anecdotally from folks that feels like taking steps backwards, but really that our goal is not backward steps. This is a kind of a foundational data-driven payment arrangement to get us to the point of being able to purchase value. So just wanted to put that out there as a kind of a critical step so we can gather what we need.
Just to build on that a little bit, it's super critical for the behavioral health providers that we're working with in the Greater Columbia region for us to really focus on making sure that we're getting encounters into the MCOs, because that's really going to be the foundation to having these conversations in the future.
Amen.
Doesn't that seem like, I guess my pushback on that is that if you know what value is, let's talk about using the payout measure. Like, why are we pushing for that? Why are we pushing for what value base could be? I mean, if we're talking about going from A to B, and you're really wanting A to Z, then let's set the groundwork for that. I don't want to go back to counting widgets if widgets isn't going to produce value. I mean, it seems like we're setting ourselves up for failure, because then I'm going to go back to my staff and say, guess what? We're going to cut your time down, and now instead of having 50 minutes, you're going to have 25 minutes. And we're going to double the number of clients you're seeing. We're not going to get the quality out of that, but we're going to have the widgets. So why not push the system and say, let's move something forward to what value-based could be. Let's use our electronic medical records to be intelligent medical records instead of dumb documents.
So that's a valid point, Chris. I mean, you have to, right now, our premium is a widget-based premium. Yeah. So that's a question that we can't really, direct as MCOs. We don't pay ourselves. So that's a great point, where you have a premium payment that's coming in that is not aligning necessarily with the execution of delivery of care that we're being, pushed to do. So, but that's not to say that we can't focus on things exactly like you're talking about. We can do that. We do have to have a core set of data, right, that Megan was talking about, to help support that. but they can happen concurrently. But I mean, it's a valid point. I mean, the way the state allocates, you know, how much we get from in our premium is very much based current.
My concern is that we implement healthcare stratification. We've got a patient registry model, and yet our primary care partners get the benefit of that because the patients get well and the cost goes down. The contradiction is that we make the investment and then the money is invested somewhere else. So I want to push this forward and use our medical records to the limits of capacity, but we haven't had that interaction where we're taking the data and being able to turn around and say, here's the value we can with what we've got from the PAM, but that may not be in our current contract, it may be in our next contract, but it's something that's like, we've got to continue.
And I think it's nuanced. Not every, you don't have to take every provider back to a fee-for-service arrangement if they're doing EHR registries, and you can show the value of services. I think for some providers it is maybe a challenge to show this is the cost of care, this is how we value care. And so a tool to do that is to have fee-for-service as a way to measure cost and value. So if providers, sounds like, you know, I know Catholic has done a lot of work in registry-based care and being able to capture the value of your clinician's time. So that, you know, not necessarily having to go back, but just as an example, you guys are doing it, you're an Imagineer, right? So the innovation is happening, and I know the next iteration of contracting could be value-based.
We have a question or a comment on the phone as well. For the MCOs, data from 10 different payers in different formats, secure email documents, and separate portal, EHR integrated applications are really challenging for our staff to navigate and include in their care. One, site source for viewing, analyzing data for all payers that has nimble filtering tools would be ideal.
We agree.
Anyone want to take that?
I mean, yeah, it's well said. I think we're all on board with that idea. True population health is, you have to have data that's manageable and that is ideally centralized. I mean, I think JD mentioned a little bit about the all-payer claims database. You know, maybe there's a chance that that could become that thing. I'm not going to hold my breath. I'm sure you aren't either. But yeah, we're totally agree with that sentiment. But I'm not sure how to get there. We would love to take your ideas, but I think there has to be a central leading party that drives that forward. And since, from my perspective, that would be HCA, and I think they're trying at least.
But isn't it true that in some of your contracts, and maybe it's health homes, that you are required to have separate portals, so that it was an HCA contractual requirement? So it's not, you know, I think that it's important to understand that you guys would love to have this too. So we really need to be working together, I think, with the healthcare authority to make this improvement.
Okay.
Yeah, and I would echo that, and I think going back to a statement that JD made, looking at the number of payers that submitted surveys. The healthcare authority also has the power of the purchaser. That's one of the key tenets of the healthcare transformation work with respect to managing Medicaid, public employee benefits, state employee benefits, or school employee benefits now. And so just that recognition of we can move the needle, and we hope that we could move into that space with respect to where Medicaid lies too, but there's always going to be then yet another payer, and so I think as we can toward the line, this is going to be great, but I do think there has to be some leadership from the healthcare authority in moving that conversation forward as well.
And knowing that that's not where we are quite yet, I think that's why it's so critical to have a good two-way conversation on, you know, how we can make the data that we do provide to you more digestible, usable, helpful.
I think also just following up on that, sorry, popped my head to make a point, giving us feedback as to how you're getting data from other plans. I think that'll help encourage us to align. Sometimes some of that work is proprietary and it's hard to share. So as you all can give that feedback back to us, what measures are other plans essentially asking of you in those arrangements? There may be a desire to want to align to that. It may be that we're having different groups or populations, and so there may be a desire to have a different focus. But again, I think feeling like there's certain things that you can't share related to rate and certain elements of the contract. But I think the idea of how is data being collected, what measures are being asked of you, that is information that's going to be helpful for us to try to be responsive and aligned with that as well.
On that measures point, I just want to say I think it's been really helpful in the last couple of years as HCA has rolled out its value-based payment strategy that they had a set of common measures that they were holding all MCOs accountable for, so that whenever we went out and had conversations with our providers about, okay, what are you working on? Here's the things that are of interest to us. Those measures are always familiar because you guys were bringing the same list of measures, and that's so helpful that we were all aligned and trying to work on those same population health goals. I'm interested to see what happens in the next couple years as there are MCO-specific measures. And I give HCA a lot of credit that they are trying to keep them as aligned as possible and at least within the same, disease categories to keep it on the same spectrum. But that is something that I'm a little disappointed is changing slightly, but we'll see what happens.
Any comments, questions?
So I wanted to kind of loop back to the question that Sam had asked culture, because I think there's times when we pay really neat lip service to challenges that we're facing, and then we retreat behind our walls. So we have a fantastic conversation about how providers can collaborate with one another and how they have to work together to provide various services. And yet, this information is proprietary, this information is proprietary, this information is proprietary. And then, on another level, in the measures, it's, and I don't know what this word means, so somebody may need to explain it, but it doesn't sound very supportive to me. When we have talked about bidirectional integration, and then you see measures on mental health penetration, SUD penetration. Nothing that goes from feeding the wisdom, knowledge, background of behavioral health providers back into this medical model that feels like it has to get stripped back down. So unlearn everything that we have learned from behavioral health providers back to a fee-for-service model. And then move forward with measures that are sort of acceptable within the medical philosophical approach. And I think there's a kind of a core cultural issue of what are we actually going to talk about? Because I know for me, when we talk about how that cultural shift happens, for me, I need to know what words. I mean, the example that I had as a clinician, the first time I went into a finance meeting and they started talking about ROIs, and I'm like, why do we need to release this information? How does that apply to any of the things that you guys are talking about? So when we talk about practice transformation, even when we talk about things like teams, measures, or any of those things, we may be saying the same words, but we are not speaking the same language. And until we get that worked out in a much more practical way, it feels like the cultural shift, alignment, and true collaboration is really just going to be kind of a nice finger.
Very well said. I think you've made strides in speaking the same language across sectors, but and I think venues like this let it happen, but there's only a sector of your staff that are present, right? So at a leadership level, perhaps, how do you take your access to your and I think in in a lot of ways, the leaders are here that are going to shift the culture. And so if kind of the venues like this you think are not meeting the needs of how to have the medical side and the behavioral health side more collaborative, I think we are welcome to hear that. How can MCOs support common vernacular? I think, in our symposiums, a lot of you were present in our IMC symposiums, and we learned a lot about access to care means different. When it's in this setting, access to care means different in that setting. ROI, there's a lot of vernacular that we use that is really specific. So would love to hear insights that y'all might have that MCOs can help bring it together even more.
Questions coming?
Hi. Practice transformation is more than just a clinical issue for Catholic Charities. We moved from a very small billing and finance department to now a integrated staff of like 11 plus data analysts that are now working on our contract. So, and that's within the last 2 years. So for us, practice transformation has also meant the reality of market forces. That if we're going to be successful, it means that we have to have a deep bench when it comes to financial analysis and data.
Absolutely, I think, and I don't mean to hesitate with that, but I think according to CARE, our financial team had to learn the behavioral health vernacular. What's an IMD? Like all these kind of things that were totally new to us, and so I think we're learning together in that way. Clinical practice transformation is understanding at all levels as how does behavioral health integrate into managed care. And another comment, I forget your name, sorry, you were just talking about. Yeah, and you were mentioning like the penetration rates as a way to measure value, and those are the ones HCA selected, and it's really what he just gave us. Do I think they're the right ones to help measure the value? No, but that's what he just has for behavioral health. So I think that's like a national policy conversation of how do we include behavioral health in a more meaningful way when we're driving quality and having standard measures.
Actually, just to add on to that, I'd love to hear if you do have measures of success that you prefer to use. That's just a learning opportunity, I think, for us. If there are measures that you use for your own staff or to measure your patient success, I think that'd be really helpful for us to understand and to try to bring back to HCA too.
Anyone want to talk about their metrics that they're currently measuring? Chris?
Sure. That's another part of the title.
So basic ones. We're looking ER coverage penetration rates. We're looking at the number of intakes that we're doing year over year, quarter over quarter. One of our big measures. So North Central and Greater Columbia, for us in North Central, looking at the rates of hospitalizations, especially in the Eastern State, has been one of our baseline measures that we've looked at. We looked at conversions out of hospitals, time between transfer of care, coordination of care, levels of care. We have 600 plus data points to track in our electronic medical record, and then plus our healthcare transformation pieces that we built in around stratification. So those are some of the things that we're using to measure quality.
helpful information. I think one of the other comments that I'd make about the penetration measures is that we as managed care organizations have had trouble in getting to the same rates that the healthcare authority and RDA has pulled forward for those penetration rates. So it makes it more difficult for us to include those types of measures in arrangements to be able to assess or have a quality component within potentially behavioral health specific contracts. And so that idea of feedback and elements of quality that you all are tracking is really important information for us to gather and bring forward as we think about what are proxy measures to the penetration measures that the healthcare authority is pulling forward that are just really pretty challenging to place into a contract with respect to that. So thank you for sharing.
Can someone give me an example of metrics that you're doing for SUD clinics or organizations? Matthew, you want me to call you out? Okay.
We don't do SUD through our office right now. Our office is focused primarily, our largest program is the WISE program. And all of the, well, aside from our in-house metrics that we have, how many data points that we're tracking, the two large metrics are ones that are actually assigned by and run by the HCA, which are the CAN, Childhood Assessment of Needs and Strengths, and then also their implementing, which is sort of the assessment, but it's a progressive assessment that's redone every so often to show improvement in a variety of domains. And then the other is called QIRT, Quality Improvement Something Tool. But it's an in-depth kind of designate way of looking into a single individual's chart. And they gather all of the data of who met with who for how long, when, how much was face-to-face, how much was over the phone, what the impact of that was. So those are both measures that we are required to use and sort of guide our practice through, both of which are constructed and governed by the HCA. So I would say, again, if you want to know what measures, at least they use for the WISE program itself and for child and adolescent mental health, those are some of the major ones.
Jenna?
I can actually speak to, for practice transformation, as you know, we require all of our sites to do risk stratification based on your highest risk population. For our SUD folks, a commonality amongst all of them has been pregnant and postpartum women, and then individuals using IV drugs. So that's been pretty much all of our standalone SUDs have identified that group as a group that needs the attention. So that can answer the measures question. But I also have a comment.
Yeah.
So recently, some of our staff, we listened to a webinar that I can't remember who put it on, but it was across 11 states, specifically speaking to behavioral health and value-based purchasing and how they've done it in other states, and they've been able to successfully implement it. And it was one of the key things, two of the key things were trust and relationships and conversations like these that happen frequently, where you're getting input on what the measures could be in some of those innovative contracts that naturally might be proprietary, but just getting some examples of what those could look like from the MCO perspective, and then having that be kind of countered from the actual practice perspective. So I think there's a real opportunity to have more of these conversations when it comes to value-based purchasing, specifically for behavioral health integration.
Was it put on by CHCS and the National Council, perhaps?
Yes, yes, it was.
They came out with a report that really reflects probably the discussion of the webinar, I would assume. And and Christian, actually, from the Washington Behavioral Health Council, was interviewed for that report. And in reading the report, about 30 pages, it's a great report. It really, I think, highlights a number of things that have been elevated here, both related to the individual, the MCO to provider, maybe some of those challenges, but it also talks at a higher level of some of the challenges at the state regarding measurement, both with respect to quality measures, but also about how we measure value-based payments. And I think that that's also a really important and very sort of nuanced component of this work as well. As we look at the percentages and as they continue to grow, the idea of what is being measured and how you measure it and the definition of that. And so, for example, as we look at the percentages across the regions, so we have Greater Columbia within, I think it was 47%. But there may be a number of providers that, again, it goes back to attribution and assignment of patient lives with respect to models. And you may have a total cost of care model that may be attributed to a number of lives that may take in hospital, behavioral health, other types of payments. And that total cost of care model counts for a much broader population participation or payment participation in that measurement. So I think sometimes it's challenging when we think about submodels underneath that and how that is reflected. And again, I know that's sort of wonky, and the land is an interesting thing that I've really delved into a lot. But I just think that as the state is starting to look at that and we're considering ways in which we can encourage increased value-based payment engagement, this idea of how we measure that may not be supporting that movement towards a more diverse engagement of arrangements across different providers.
And that information is on our website, from that webinar that was we attended. So if anybody wants that information, it's on the website.
Merit would like to also, Merit currently is working on improving referral to PCP or connecting patient with a PCP if they do not have. We are measuring depression and PTSD on COD patients, also reducing homeless in COD and SUD patients, using EDDI to track ER frequent flyers and follow up with them. Bearing in mind for SUD, COD patients, IMC means things like finding a home, reuniting with family, getting a job, overcoming legal issues. The list goes on before we get to a patient who worries about their diabetes.
I know there's a comment, but one thing I wanted to say off of that, I'm sorry. Coordinated care, we were lucky enough to do a CMS application with the healthcare authority called Integrated Care for Kids, that if awarded, we'll find out in the next couple of months, we'll launch in January, and it's gonna measure things like that for the pediatric population. So stable housing, access to food, kindergarten readiness, truancy over the lifespan, so through the school age. And so I think there are models that will be tested. Hopefully Washington selected to be one of them. But you know, that's a great point. Someone who doesn't have a place to live needs to find a place to live before they worry about their some of their healthcare needs.
Teresa Atkinson from Triumph Treatment Services, and I supervise our PPW program. So when we were starting the practice transformation project, we looked at some of the things that we usually see as the biggest barriers to treatment. But we've been tracking, IV drug use and pregnancy, postpartum for a long time. So we didn't want to go with what we'd always kind of done. The point was to do things we hadn't done. And because we are looking at one of our residential programs to do this project, we actually did go with diabetes, depression, and unhealthy relationships as the three of the things that are really big indicators on whether or not a patient's going to be successful in their treatment and their recovery long term. So, I mean, with bearing in mind the idea of like, how do we implement new things? We can go with just regular, not regular, but we serve pregnant parents and women. A lot of them, opiate use disorder, IV drug use, that's our population. So we needed something a little bit different. And because we're residential, we didn't look at the homelessness thing. So I kind of wanted to piggyback on what other people were
So I realize we're talking a lot about the patient-centered care, the whole patient experience, improving the quality of their lives. The one thing you've got to keep in the back of your mind, no matter who you are or where you are in your facility, the benefit overall that needs to be seen is a decrease in healthcare costs and an increase in improvement. So there's a lot of things you can measure that you can't, it's really difficult to track how much you can save. So I think for me, there's some of those things I'd love to be able to track. I need to know what is the cost if we don't have some of these improvement areas. So I think that's an issue that we've got things that we really need to measure. I don't want to say it's cheap for somebody to be homeless, but we need to be able to, like, people come in and say, okay, because somebody's homeless, you're going to spend more here, 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 and here. And I think that's difficult for some of us to wrap our heads around. Okay, what is the whole cost? We talk a lot about decreased recidivism for jail. Well, payers aren't paying for people in jail. So how do you prove the cost was to have somebody in jail when the end deals don't ever or do something? I think for me personally, I don't think they have really that detailed information on how to come up with the metrics on showing that you're decreasing. Yes, my service is probably this much, you're paying me this much. Where are we saving? You know, like MAT is a huge cost savings. Over the course of 1 year, so we can, what, $30,000 compared to now on MAT. Okay, got all that data. I don't think for us, for SUP, we have enough data. Even though we collect a ton of data, we don't collect cost. Or we can integrate with that to be able to find out what is this person costing society if we don't do that. Is that something the MCOs, the HC, or the APAs can help with?
So I'll take a first crack at this. I think this goes back to what Ruth was saying earlier, a couple of things actually. One, that first we have to build that baseline of data that we don't really have from when, integrated managed care went live here. We didn't get a lot of data from the BHOs about what that cost structure looked like. So that's the baseline we're really trying to build right now. But the other very difficult component of this is that attribution that Ruth was mentioning, where in primary care, we know how to do that because we assign a patient to a primary care practitioner. But for behavioral health, we all have to figure out how to measure those costs over time. Do you track it by patient? Do you try to assign a patient to a specific behavioral health provider? There's just a lot of iterations that, at least for Molina, I know we're still trying to work through.
Well, I'd like to piggyback off of that because I agree, as an MD provider, I agree wholeheartedly with what you're sharing. The other piece that I get stuck on is when we talk about which metrics we're going to choose for IQE and how we can actually show that somebody, quote unquote, was successful or improvement. How do you rate improvement? Because our previous metrics were very punitive. Like, we were encouraged to get people into lower levels of care to prove that we were helping them. But if they have level of care of 2.1 and they need to stay in there longer, I see that as an improvement because they're engaging, but previously that was you're not improving because they're not going down to 1.0 fast enough. I'm worried as an FD provider that the measurement of improvement is first of all going to be subjective or not agreed upon, and secondly going to be punitive for ASAM.
I love that point. I think recovery oriented isn't necessarily a HEDIS value. But I think one that comes to mind that could help, the initiation, engagement, treat measure doesn't say what level of treatment. So, if someone is initiated and screened and assessed, do they engage and actually make it to treatment is something that doesn't matter what level of ASAP they're in. But absolutely, I think recovery needs to be infused, particularly in our behavioral health culture and how we measure, but all across healthcare.
And I would say that MCOs, I think they do have the resources to do a cost-benefit analysis in regards to what are the attributable cost savings for keeping somebody stable in a house and employed, right? I think we do have those resources to be able to do those types of things. But back to Melina's point, I don't think we're there yet because you do have to have a fundamental base or something that you can work with in order to do that. So I definitely see it on the trajectory of where we're going with value-based payment. I don't think we're there right yet.
belabor the point, but I think it bears repeating is this idea too of as we're pushing on value-based payment, the idea of, yes, the idea is lowering costs, but I appreciate the way in which CMS has reframed that, when they reframed it in the prior administration, related to sustainable costs. Because I think the other piece too that we need to recognize is that our behavioral health system, especially in Washington, is underfunded. And so how can we get to a place where it's also sustainable costs? So how are we also working with the state and with CMS to advocate on how we can more effectively address the needs of populations and think about ways in which we can pay for certain services? Or if we see savings because we're paying for, or if somebody was housed, that doesn't sort of, going back to Courtney's earlier point, the way in which the rate structure is developed in our state is a little backwards. And while I caution not to move away from actuarial sound rates, that's not what I'm advocating for, but the idea of how do we ensure that there can be savings held so that we can reinvest that rather than that going back into a space, whether it be the state or CMS. So I think that there's sort of these larger questions where the state also can play a role because there's other agencies that see savings as well, or that see costs, so criminal justice and housing, and so just that idea of and where the ACH can play that role in looking at that cross-agency, cross-sector approach to work is also what we hope to see here too.
Any more comment on that? Apologies, Sam had to leave, so you get me now. So we have a question that we wanted to ask about contracting, specifically for BBP. So what data do you think would be helpful in contracting for value-based purchasing?
Yeah, I think that was addressed earlier. But go ahead, Melina, take it away.
Oh.
I didn't know you were grabbing the mic.
No, I wasn't, but yeah, I think it has, I think we've touched on it a little bit, maybe indirectly, but I think baseline understanding of cost and quality performance, which requires some kind of attribution one way or another. I mean, more qualitative data, I think understanding what is important to each individual clinic practice, what your priorities are so that, we're not duplicating efforts or taking you in a direction that doesn't make sense for your practice. I think that's really important.
Okay. Oh, go ahead, Barb. Or wait for the mic.
I'm feeling like totally out of it because I don't understand why behavioral health patients are not attributed to a specific provider, just like primary care patients are attributed to a primary care provider. I've been a behavioral health provider for a long time. Do I not understand something?
Yeah, it's a great question, and hopefully you all can join in on this too. So it's I think attribution generally, even in the primary care space, it's super challenging, right? And I think we're trying to avoid those same pitfalls in the behavioral health space. I think we've learned some industry standards about how it's done, namely look at, this is dumb, but look at who someone is going to, who they've gone to multiple times. I think in our initial look at our data, we're finding that our patients go to multiple behavioral health practitioners. So how do we choose between those? Is it the one that costs the most? Is it the one that they've gone to one more time than the others? Is it the one that they've gone to most recently? So I think as we build this baseline of data, we're trying to understand that more. I don't know if you all have other.
I think the simplest answer is it's been a historical practice on the primary care side, and it hasn't been in behavioral health. So just to your point, we're just trying to get there. So.
Behavioral health is a specialty, right? And so when MCO is assigned, we assign a population to a primary care provider to be their medical home. And that person may or may not be utilizing services. So that primary care provider is incentivized in ways to go and find members who are not utilizing. We haven't done that with behavioral health, assigning a population that is, you know, that is yours to engage, whether or not they've walked into your door or not. So that's a model we haven't done. And not to say that behavioral health providers can't be in medical home. There's many folks with more serious behavioral health conditions, the SPMI, SED populations, that we are trying to get to bidirectional integration to where they can be served within a behavioral health setting. And it's kind of all about how we, as payers, credential you. Are we credentialing you as a primary care practice and provider so that we can attribute a population? So some of it's historical, like Courtney said. Some of it is just how do we assign a population to a specialty provider that may never access your services, whereas everyone, hopefully, the goal is to access a medical home, a primary care medical home.
Okay. We have one last question we wanted to ask as an ACH, and it's a pretty selfish question, but any other questions or comments from the audience before we ask our last question, our last few minutes? Yes. Martine's coming with the mic. Ronnie.
Oh, thank you. So in the perspective of consumers as well as an outreach person, peer support, I wanted to ask a question: why is Medicaid not covering direct services when a lot of these folks that you guys are talking about need those direct services in order to get through the process of getting through the doors of care? Some of my clients have not had an ID in years, have not had access to housing, and are barred from housing because of their background. They don't have rental history. They don't have an income, but yet they're getting a voucher so that they can get into housing. And then they need to get through these systems that they have no clue how to get through these systems. And I know that I can't just hand them an address and say, hey, go over here and talk to so-and-so, because they don't even know what they're talking to them about. If I send somebody over to the Northwest Justice Project and say, well, you need to get a reasonable accommodation to get through this door, they have no idea what I'm talking about. So if there's direct services that will help them get through those barriers, we'll find more success at the other end. But our outcomes are not going to be good when we're talking about we're doing all this transformation, but without direct services being paid for, it's not going to happen. And your outcome numbers are going to be lower because there's not somebody there helping them through those services and those barriers to that housing, to the care that they need. Really doing a lot of advocacy work so that they can get past those barriers. So why is that not being looked at as a piece and outreach being implemented in these silos of care? Because I think that that's really an important piece that's not even being looked at. I'm done.
So I think that's a great question. I don't know what your definition of outreach or direct services, but I think what you're talking about is kind of care coordination, even before someone is able to access healthcare. How do we get some of their basic needs met? Is that what direct services mean? Or how would you define it?
Care coordination is one thing, but actually having somebody on support while the person is getting through those care systems. Sure. Because a care coordinator can sit down and they can say, well, we need this, we need that, we need this. And they're on board with the care coordinator at that time, but actually implementing those ideas and structure behind that care coordination is now put on the shoulders of the client, and the client is at a loss of how to do that. Having someone being able to support that client through those doors is the direct services, and I'm understanding because I am a peer support as well as CHW. those services are not paid for through Medicaid. If I was an entity trying to get my clients through those things outside of mental health services. So in my job form, I can do that because I'm on board as a peer support. But if I was an entity out there, an agency or an organization that didn't have mental health support, those are not paid for. So if somebody came to me and said, well, I want to have a business with direct support, it's not going to be paid for by Medicaid. And most of the clients that I see are Medicaid recipients.
Yeah, thanks for that definition. So I think a couple of comments. I think the Medicaid state plan is what it is. We can, MCOs can only cover benefits that are in there in terms of what we can reimburse providers for. But there are community health workers that work with us all that do that work. There's not enough of them. I'll give you that. We would like to put more in the community. But, we've got, I just was talking about an example yesterday about how we were assisting one of our members to understand that they needed a pet agreement in order to continue with their lease, or else they were going to be forced to enter into homelessness. And I think kind of just examples like that of where we do more than just healthcare absolutely happens. But you would find advocates in all of us if we want to, look at lobbying the state to add and expand benefits like that for our population. And I know, part of the transformation waiver is supported housing, supported employment. Those are right now managed by Mayor Group, but will be part of all MCO benefits in the future. So I think there are ways that the state is trying to support what you're talking about. It's not perfect yet, but what I got to say.
I would echo what Ruth said. Molina has case managers that can help coordinate, not just coordinate scheduling an appointment to get direct services, but if the member needs somebody to go with them to make sure that they can make it to the appointment or arrange transportation, we definitely have folks that can try to help fill some of those gaps when needed.
So we have about 2 minutes left, and in our last question, just for the panel, what do you think the ACH is doing well, and how could we improve from the MCO perspective?
So I can start with the CAT. I think a couple of things that have already been noted is there was a lot of work up front to establish what can and should the ACH focus on. And one of the key areas that a lot of resource and energy has gone into is around the practice transformation efforts with respect to having one-on-one coaches out in clinics. And so looking at the cohort approach, really establishing a shared and very transparent approach to measurement as providers move through what those milestones are that are really based on the core tenets of primary care medical home. And I think when we say that initially, it felt restrictive, but as you start to expand what those core tenets are of a medical home model, they can really apply across a number of different practices. And so really focusing energy and attention on that, I think, has just been such a great work on the part of the Greater Columbia ACH. And within that space, what I mentioned as well is the transparency around that. Greater Columbia ACH, in my opinion, is one of, if not the most transparent ACH across the state. And what that helps us as a managed care plan better understand is how can we align with that work? How can we partner to complement that work that's happening within the provider space so that we may not duplicate that, or again, we can complement and come alongside with that. So I think just really appreciate that effort on behalf of the Greater Columbia ACH.
Thank you.
I would just say that you just have chosen the pathway to work on, and I think the GCACH is focusing on the medical home model has been really essential to the fundamentals of value-based payment. So I think that's gone really well down here. And the resources that GCACH has internally in regards to, the breadth of knowledge that the staff has, I think, been really valuable. And so, you know, where other ACHs are lacking. So I think those are two main points from our perspective.
I would say from an IMC perspective, you know, all the work that the ACH did leading up to implementation was really helpful. Thank you. For you guys to function as the convener of the providers and the MCOs, and it's been a very collaborative approach, and we're really looking forward to transitioning to some of these other topics now that we've implemented IMC.
So we are out of time. You can email us how you want us to improve. But can we give our panelists a round of applause? Thank you. So thank you all for attending. Our next dates are on the agenda sheet of our next Learning Collaboratives and Leadership Council. So thank you.